Pulmonary fibrosis is a respiratory disease in which scars have formed in the lung tissues, leading to serious breathing problems. Scar formation, the accumulation of excess fibrous connective tissue, leads to thickening of the walls, and causes reduced oxygen supply in the blood. As a consequence, patients suffer from perpetual shortness of breath. In some patients, the specific cause of the disease can be diagnosed, but in others, the probable cause cannot be determined. A condition called idiopathic pulmonary fibrosis. There is no known cure for the scars and damage in the lung due to pulmonary fibrosis. Signs and symptoms. Symptoms of pulmonary fibrosis are mainly shortness of breath, particularly with exertion, chronic dry, hacking coughing, fatigue and weakness, chest discomfort including chest pain, loss of appetite and rapid weight loss. Pulmonary fibrosis is suggested by a history of progressive shortness of breath with exertion. Sometimes fine inspiratory crackles can be heard at the lung bases on auscultation. A chest X-ray may or may not be abnormal, but high-resolution CT will frequently demonstrate abnormalities. Cause: pulmonary fibrosis may be a secondary effect of other diseases. Most of these are classified as interstitial lung diseases. Examples include autoimmune disorders, viral infections and bacterial infection like tuberculosis, which may cause fibrotic changes in both lungs' upper or lower lobes, and other microscopic injuries to the lung. However, pulmonary fibrosis can also appear without any known cause. In this case, it is termed idiopathic. Most idiopathic cases are diagnosed as idiopathic pulmonary fibrosis. This is a diagnosis of exclusion of a characteristic set of histologic, pathologic features known as usual interstitial pneumonia. In either case, there is a growing body of evidence which points to a genetic predisposition in a subset of patients. For example, a mutation in surfactant protein C has been found to exist in some families with a history of pulmonary fibrosis. Diseases and conditions that may cause pulmonary fibrosis as a secondary effect include inhalation of environmental and occupational pollutants, such as metals in asbestosis, silicosis, and exposure to certain gases. Coal miners, ship workers and sandblasters among others are at higher risk. Hypersensitivity pneumonitis, most often resulting from inhaling dust contaminated with bacterial, fungal, or animal products. Cigarette smoking can increase the risk or make the illness worse. Some typical connective tissue diseases such as rheumatoid arthritis, SLE and scleroderma. Other diseases that involve connective tissue, such as sarcoidosis and granulomatosis with polyangiitis. Infections. Certain medications, e.g., amiodarone, bleomycin, busulfan, methotrexate, apomorphine, and nitrofurantoin. Radiation therapy to the chest. Pathogenesis. Pulmonary fibrosis involves gradual exchange of normal lung parenchyma with fibrotic tissue. The replacement of normal lung with scar tissue causes irreversible decrease in oxygen diffusion capacity, and the resulting stiffness or decreased compliance makes pulmonary fibrosis a restrictive lung disease. Pulmonary fibrosis is perpetuated by aberrant wound healing, rather than chronic inflammation. It is the main cause of restrictive lung disease that is intrinsic to the lung parenchyma. In contrast, quadriplegia and kyphosis are examples of causes of restrictive lung disease that do not necessarily involve pulmonary fibrosis diagnosis. The diagnosis can be confirmed by lung biopsy, videoscopic assisted thoracoscopic wedge biopsy, and a general anesthesia may be necessary to obtain enough tissue to make an accurate diagnosis. This kind of biopsy involves placement of several tubes through the chest wall, one of which is used to cut off a piece of lung to send for evaluation. The removed tissue is examined histopathologically by microscopy to confirm the presence and pattern of fibrosis as well as presence of other features that may indicate a specific cause, e.g., specific types of mineral dust or possible response to therapy, e.g., a pattern of so-called non-specific interstitial fibrosis. Misdiagnosis is common because, while overall pulmonary fibrosis is not rare, each individual type of pulmonary fibrosis is uncommon and the evaluation of patients with these diseases is complex and requires a multidisciplinary approach. Terminology has been standardized, but difficulties still exist in their application. Even experts may disagree with the classification of some cases on spirometry as a restrictive lung disease. Both the FEV1 and FVC are reduced, so the FEV1-FVC ratio is normal or even increased, in contrast to obstructive lung disease where this ratio is reduced. The values for residual volume and total lung capacity are generally decreased in restrictive lung disease. Treatment. Pulmonary fibrosis creates scar tissue. The scarring is permanent once it has developed. Slowing the progression and prevention depends on the underlying cause. Treatment options for idiopathic pulmonary fibrosis are very limited. Though research trials are ongoing, there is no evidence that any medications can significantly help this condition. Lung transplantation is the only therapeutic option available in severe cases, since some types of lung fibrosis can respond to corticosteroids or other medications that suppress the body's immune system. These types of drugs are sometimes prescribed in an attempt to slow the processes that lead to fibrosis. The immune system is felt to play a central role in the development of many forms of pulmonary fibrosis. The goal of treatment with immune-suppressive agents such as corticosteroids is to decrease lung inflammation and subsequent scarring. Responses to treatment are variable. Those whose conditions improve with immune-suppressive treatment probably do not have idiopathic pulmonary fibrosis. For idiopathic pulmonary fibrosis has no significant treatment or cure. Two pharmacological agents intended to prevent scarring in mild idiopathic fibrosis are pirfenidone, which reduced reductions in the 1-year rate of decline in FVC. Pirfenidone also reduced the decline in distances on the 6-minute walk test, but had no effect on respiratory symptoms. The second agent is nintedanib, which acts as antifibrotic, mediated through the inhibition of a variety of tyrosine kinase receptors. A randomized clinical trial showed it reduced lung function decline and acute exacerbations. Anti-inflammatory agents have only limited success in reducing the fibrotic progress. Some of the other types of fibrosis, such as non-specific interstitial pneumonia, may respond to immunosuppressive therapy such as corticosteroids. However, only a minority of patients respond to corticosteroids alone, so additional immunosuppressants, such as cyclophosphamide, azathioprine, methotrexate, penicillamine, and cyclosporine may be used. Colchicine has also been used with limited success. There are ongoing trials with newer drugs such as IFN-gamma and mycophenolate mofetil. Hypersensitivity pneumonitis, a less severe form of pulmonary fibrosis, is prevented from becoming aggravated by avoiding contact with the causative material. Oxygen supplementation improves the quality of life and exercise capacity. Lung transplantation may be considered for some patients. Prognosis. Hypoxia caused by pulmonary fibrosis can lead to pulmonary hypertension, which, in turn, can lead to heart failure of the right ventricle. Hypoxia can be prevented with oxygen supplementation. Pulmonary fibrosis may also result in an increased risk for pulmonary emboli, which can be prevented by anticoagulants. Epidemiology. 5 million people worldwide are affected by pulmonary fibrosis. A wide range of incidence and prevalence rates have been reported for pulmonary fibrosis. The rates below are per 100,000 persons, and the ranges reflect narrow and broad inclusion criteria, respectively. Based on these rates, pulmonary fibrosis prevalence in the United States could range from more than 29,000 to almost 132,000. Based on the population in 2000 that was 18 years or older, the actual numbers may be significantly higher due to misdiagnosis. Typically, patients are in their 40s and 50s when diagnosed, while the incidence of idiopathic pulmonary fibrosis increases dramatically after the age of 50. However, loss of pulmonary function is commonly ascribed to old age, heart disease, or to more common lung diseases.